Nearing the end of my graduate program, when I started my grad school project, it eventually evolved into a capstone that focused on healthcare transformation. And as part of the project, I had the chance to sit down and interview Dr. Brent James, who was then the Chief Quality Officer at Intermountain Healthcare. So, as a leading expert in healthcare delivery, policy research, and quality, he provided some invaluable insights that made this one of the most educational experiences of my life. So, here I wanted to share it, give you some portions of the interview, and give it a little bit of a broader reach. So, I hope you enjoy.
My name is Brent Carl James, usually just go by Brent James. Have an MD degree, a Master of Statistics degree, MStat. I'm Intermountain Healthcare's Chief Quality Officer. I am the Executive Director of the Intermountain Institute for Healthcare Delivery Research. I'm a member of the National Academy of Medicine, part of the National Academy of Sciences at a national level, hold professorships, a tenured professorship at Stanford University, adjunct professorships at the University of Utah and Harvard School of Public Health. So the history of medicine is a story of change. It's ongoing change for at least the last 3,000 years. It's accelerated in the last 100 years. Now, it's easy to make the case that care delivery today is the best the world has ever seen. People alive today get far better health care and far better health than any previous generation of people living on this planet. Easy case to make on the evidence. That said, it's the duty of every generation of the healing professions to pass along to the next generation something better than we ourselves received. And that's what we're in the process of doing, is passing along something better. One of the first steps in understanding that is to understand where your opportunities are. Back in 2009, I was testifying to the Senate Finance Committee in the run-up to the ACA. I took the variation literature, a massive literature about variation in care delivery, not just geographic variation that Wenberg and the Dartmouth Atlas documented so well. You can measure variation within a single hospital, very significant variation within a single physician. Interestingly, the rates of variation in nursing are probably higher than they are in medical practice. The highest level of variation I've ever personally found is in physical therapy. So endemic across the healing professions, this idea of variation, divided it into 5 major subcategories. Number one, general geographic variation. It turns out that where you live is more important than whether you have health insurance in determining the care that you'll actually receive. It's deeply professionally troubling because the variation is so large that it's pretty much physically impossible that even with full access to care, all people could possibly be getting best care under the current system. The second major area is called inappropriate care. If I had a poster child for that, it'd be Bob Brook, a senior professor of internal medicine at UCLA, the chief medical officer at RAND at the time this work took place. He and, well, many other researchers said perhaps we can explain geographic variation by inappropriate care. Now, their definition of inappropriate, care was judged inappropriate if the risk inherent in the treatment outweighed any potential clinical benefit to the patient. This in professions that hold as our primary maxim, first do no harm. These would be areas where we put patients actively in harm's way. They had 2 major findings from that body of literature. The first, it turns out that inappropriate care does not explain geographic variation. Low utilization communities, on average, have about the same amount of care judged clinically inappropriate on careful review by one's peers as do high utilization communities. Secondary finding, though, that was much more deeply troubling, well, the high water mark in that initial set of studies, 34% of all carotid endarterectomies performed in the United States, clinically inappropriate. The innate risk outweighed any potential benefit should never have been undertaken, but it was. Since then, we've had other trials that suggest the rate may even be higher in some specific areas. Courage trial in cardiovascular medicine suggests that half of all cardiac stenting is clinically inappropriate. Very controversial, as you might imagine. That was item number 2. If you think number 1, geographic variation, was clinically challenging, professionally challenging, number 2 overshadows it completely. Number 3, November 30th, 1999, the Institute of Medicine publishes a report called To Err is Human. Within that report, we estimated somewhere between 44,000 and 98,000 Americans die each year in hospitals where the cause of death is not their underlying disease, but the treatments we used to address those diseases in a way that two independent physician reviewers separately agreed was avoidable. It makes healthcare delivery somewhere between the fourth and sixth most common cause of preventable death in the United States. Now, subsequent to that, I was a member of the IOM team who wrote that report, by the way. Subsequently, we've conducted further research that suggests the real number is closer to 200,000. Now, you have to keep that in perspective. The evidence suggests that we add about 3.5 to 7 years of life expectancy on average to every member of U.S. society net of those injuries. So the upside is hugely bigger than the downside. It certainly shouldn't steer anyone away from receiving healthcare when they need it. Most people didn't seem to read the second half of the report, though. What we pointed out is that we had proven methods by which you could dramatically drop the injury rate without losing any of the benefit.
Well, there's no news like that.
Well, I'm going to come back to this, but the right way to think about it is an opportunity. It's the right way. But number 3, patient safety. Number 4, we called them injuries of omission. So patient safety are injuries of commission where the care actively harms. Injuries of omission, I have hard evidence of benefit. They tend to be non-controversial. How well do we execute? Probably the best studies in this area come from Beth McGlynn when she was at Rand. Beth is now at Kaiser Permanente. Beth showed that for adults, we managed to get it right about 55% of the time. For children, 46% of the time. So the way to ask the question around injuries of omission, if we can achieve miracles, as we do, when we can execute correctly about half the time, what kind of miracles could we achieve if we executed correctly all the time, or something close to all the time? You see the idea? It means we're leaving lives and pain and suffering and function on the table, that we could be much better. Lastly, if you take the top 4, you can summarize this as waste. In 2010, another IOM committee on which I served, we reviewed the literature around waste in healthcare. We concluded that a minimum of 35% and probably over 50% of all spending in the United States on healthcare delivery is technically waste. Non-value adding from a patient's perspective. We're talking 50% of a $3.4 trillion spend. $1.7 trillion in financial opportunity for the country and its people. Huge, huge upside. Well, the right way to think about this, it turns out that if you review the rest of the world, it's the same list. Most of the research is done here in the United States. We tend to invest much more heavily in research, but other countries have sufficient evidence to reach that conclusion. Canada, Sweden, Great Britain, France, Germany, Australia, Singapore, same list. It suggests that these problems do not arise from health policy at a national level, so the solutions don't come from health policy at a national level either. These are innate, endemic within the healing professions. The right way to think about it is as an opportunity. These are opportunities for better, where we could be better. Unfortunately, many politicians like to use it as a bill of indictment. I would argue that that really doesn't make sense. They like to say healthcare is broken, but for something to be broken, sometime, somewhere, it had to work correctly. So it's working, then it breaks, and then it's broken. That's not true about healthcare. It's easy to make the case that care delivery today is the best the world has ever seen. Easy case. It's just that we could be better. So as soon as you realize that, you're really putting some weight behind this idea that it's the duty of every generation of the healing professions to pass along something better than we ourselves received.